Good morning everyone. My topic of presentation is comparison of surgically induced astigmatism in SSCS and phacoemulsification. I have no financial interest. Introduction. Surgically induced astigmatism was one of the factors that influences the desirable refractive outcome. Post-cataract surgery astigmatism causes delayed visual rehabilitation and reduces the effectiveness of surgical procedure. Factors like location, direction, length, width, depth, shape of the incision, type of the sutures and suture material have been found to influence the astigmatism. The incidence of surgically induced astigmatism is more in SSCS as the incision is large, about 6 mm, compared to that of phacoemulsification where the incision size is about 2.4 mm. Materials and method. It's a prospective study. Study setting: patients presenting with cataract attending ophthalmology OPD. Sample size is 100 patients. Study duration 6 months. Inclusion criteria: patients with age-related cataract. Exclusion criteria: patients with traumatic cataract, cataract associated with pterygium, cataract associated with corneal opacity, eyes which had undergone collagen cross-linking or LASIK, eyes which had undergone previous ocular surgeries. Methods: it's a prospective study done on 100 eyes of 100 patients over a period of 6 months. Patients were randomly divided into two groups. Group A included 50 patients who underwent SSCS and Group B included 50 patients who underwent phacoemulsification. Preoperative assessment of uncorrected visual acuity, refraction values, best corrected visual acuity, refractive history, keratometry, A scan, examination of anterior segment and posterior segment were done. The two groups were compared post-operatively by assessing the uncorrected visual acuity, refraction values, best corrected visual acuity and keratometry values. Results: more number of patients are between 51 to 60 years in SSCS group. In phacoemulsification group, more number of patients are between 51 to 60 years. In SSCS group, 64% of male and 36% of female. In phacoemulsification group, 58% of male and 42% of female. More number of patients are in nuclear sclerosis type of cataract in SSCS, and more number of patients are in phaco nuclear sclerosis type of cataract. Preoperative corrected visual acuity in SSCS, more number of patients are with hand movements. In phaco group, the more number of patients are with CF 2 meters. Induced astigmatism in SSCS, the mean value was 0.74 diopters. In phacoemulsification, the mean value was 0.45 diopters. Change in astigmatism: there is no change in astigmatism in SSCS for 17 patients, 0 to 1 diopter change in 22 patients, 1 to 2 diopter change in 6 patients, 2 diopters change in 5 patients. In phaco group, there are no change in astigmatism in 25 patients. In 0 to 1 diopter change is present in 20 patients, 1 to 2 diopter change in 5 patients. Discussion: in our study, out of 50 cases of SSCS, 14 patients are between 40 to 50 years, 20 patients are between 51 to 60 years, 13 patients are between 61 to 70 years, and 3 patients above 70 years. Out of 50 cases of SSCS, 32 were male and 18 were female. Out of 50 cases of phaco, 9 patients are between 40 to 50 years, 20 patients are between 51 to 60 years, 14 patients are between 61 to 70 years, and 7 patients above 70 years. Out of 50 cases of phaco, 29 were male and 21 were female. Mean surgically induced astigmatism in present study was 0.74 diopter in SSCS, and in phacoemulsification it was 0.45 diopter. On comparing surgically induced astigmatism in SSCS and phacoemulsification, it was found that surgically induced astigmatism was less in phaco. On comparing the size of the incision, it was found surgically induced astigmatism was higher in incision size of 6.5 mm in SSCS, and in comparison to 2.4 mm in phacoemulsification. Post-operative astigmatism was against the rule type in majority of the cases group. In A group SSCS, as there was flattening in the axis of the incision. In group B phacoemulsification, there was not much shift of astigmatism axis to against the rule type, which is implicated that smaller incision don't cause axis shift significantly. Conclusion: average surgical induced astigmatism in group A was 0.74 diopter, and in group B it was 0.45 diopter, which was due to the large incision size in SSCS. Post-operative astigmatism was against the rule type in majority of the cases in group A, and in group B there was no much shift of astigmatic axis to the against the rule type. Superior frown incision showed less surgically induced astigmatism in comparison to superior scleral striate incision in SSCS. Phacoemulsification leads to less surgically induced astigmatism compared to SSCS. Thank you.
Sushma, you did not mention SICS, which like temporal SICS or superior SICS.
Superior SSCS.
That you should mention. You did not mention the size of the incision, what you have taken, whether it was only 6 mm for each case because the length of the incision for a small incision also varies the astigmatism. Superior versus temporal also varies the astigmatism. And phacoemulsification, it is whether it is clear corneal or a scleral tunnel, all have different astigmatism rates. So it is a vague study, isn't it? You, in your study itself, you should mention where you have taken for all the cases, whether it was only superior 6 SICS and phacoemulsification like clear corneal or thing. Nothing is mentioned.
Superior SSS and clear corneal phaco.
Clear corneal where superior or temporal?
Superior.
Phaco also superior. So that should be clearly mentioned. Okay, otherwise it will be a very vague. Okay, because temporal clear corneal incision does not cause any astigmatism. If it is 2.2 clear corneal incision, there is no astigmatism. It's almost negligible, 0.1. Okay.